Ladies and gentlemen, welcome to case session number 6 entitled Complex PCI. We have a great session for you. My name is Fahim Jafary. I'm a cardiologist in Singapore, and my co-moderator is Professor Dato Sim from Sarawak, Malaysia. We have a great panel, starting with Dr. Adrian Cheong from Hong Kong, Dr. Chee from Singapore, and Dr. Yoshihide Fujimoto from Japan. Each presentation is allotted 6 minutes, and following which there'll be 4 minutes of discussion. I'm going to turn the mic over to my co-moderator, Dr. Sim, to introduce the speakers, and we request the speakers to stick to their allotted time. Dr. Sim.
Thank you very much. Our first speaker is Dr. Mahmoud Ramadan from Tan University Hospital, Egypt, and he is going to share with us, can aortic cusp dissection be managed conservatively? Please, Dr. Ramadan.
Hello, everyone. I'm Mahmoud Ramadan, cardiologist from Tanta University Hospital, Egypt. I'm presenting to you this case on behalf of Saturday primary team and my colleagues, Dr. Osama Shoaib and Dr. Mahmoud Khalil. And it will be on a very important complication during angiography. Can aortic cusp dissection be managed conservatively? Our case today is 58 years old male, hypertensive, ischemic heart disease with history of coronary angiography that showed mid-segment chronic total occlusion of LED and he has recurrent chest pain. The patient was referred to our center for elective PCI, and his physical examination at time of admission showed stable vital signs with heart rate about 75 beats per minute, blood pressure 130/80, respiratory rate 15 cycles per minute, random blood sugar 118 milligram per deciliter, and heart sounds normal, lungs clear. Investigations revealed ECG of normal sign of rhythm without significant changes, creatinine 0.2 milligram per deciliter, and 2D echocardiography, regional wall motion abnormalities of anterior wall with fair LV systolic function, ejection fraction about 50%, with mild mitral incompetence. Myocardial perfusion scan shows viable anterior wall with reversible ischemia. And here is his coronary angiography that shows RCA has non-significant lesions giving retrograde collaterals to CTO mid-segment LED. Again. Our steps during PCI to CTO LED, we have bilateral radial access, guiding XB 3.5 and Shotgun Riot 4 diagnostic. Anti-grade wire escalation. Wiring first, we started with Felder XT, run through intermediate, then Gaia second. After multiple trials of wiring of LED, true lumen was confirmed by retrograde injection, then regular PTCA and stenting. Here are the steps during trials of wiring to LED. The wire in the diagonal. Finally, we succeeded to wire LED, PTCA and stenting in a regular way. No problem till now. Stenting of LED, post dilatation, and the final angiographic view. But unfortunately, during the final angiogram, we noticed dissection of left main body by the catheter tip that extended when we tried to do another injection to confirm it to the aortic cusp. And here is the nightmare. This is the final view. Here is a section flap of left main that extended to aortic cusp. Again. We went immediately to stenting of left main LED by 428 millimeter drug-eluting stent, then proximal optimization and flaring by 512 millimeter non-compliant balloon inflated at increasing pressure. Final angiography showed sealing of the dissection flap at the left main with a stained dye in the aortic cusp dissection. And these are the steps of left main stenting. Adjustment of the stent, inflation and post-dilatation. The patient was asymptomatic and hemodynamically stable. Echocardiographic assessment in the cath lab of aortic root showed intact aortic cusp and no dissection flap and no pericardial effusion. The patient was transferred to CCU and was followed up clinically, and follow-up echo was done the next day with stable hemodynamics. Outpatient follow-up after 1 week showed no clinically significant symptoms nor signs. As we know, iatrogenic cusp dissection of the coronary artery and ascending aorta is a rare complication of diagnostic coronary angiography, with an incidence less than 0.1% and more commonly with CTO PCI. The presentation varies from asymptomatic angiographic finding to complete hemodynamic collapse. Iatrogenic aortocoronary dissection can be prevented by avoiding aggressive manipulations or deep intubation or deep engagement of catheters and maintaining a steady tension on the catheter while the angioplasty balloon is withdrawn. The pressure waveform should be monitored to prevent contrast injection in the presence of dampening. More importantly, it's essential to stop subsequent contrast injection that could lead to extension and enlargement of the dissection. And I would like to hear from my friends here about their preferred strategy with such complication. My conclusion is that extra backup guiding catheter like XP or are injurious to the so the operator should be careful regarding deep intubation and apply safety measures such as floating wire technique if applicable to protect against deep intubation. When doing PCI with one of these guiding catheters, we recommend always that have a final caudal view to check the integrity of the left main at the end of the procedure. And also rapid intervention with stenting to seal the dissection flap is a life-saving measure. And thank you.
It's a great case. It reminds me of a similar case more than 10 years ago. But does the patient have any chest pain?
No. We had the system stable, the guiding catheter and the guide wire stable, and it's almost the intervention done within less than 1 minute.
I think it's a great case. The important thing to understand here is that the emergency is not the left main dissection. The left main is open and the patient is okay. The patient is going to die from the dissection propagating into the aorta. And so the right thing to do is to immediately stent the ostium, find the right view of the ostium, have the stent actually protruding out a little bit so that you don't miss the ostium, and then flare it and seal the dissection. Then the rest of it you can do at your leisure. So you did the right thing. I didn't see you looking, I'm assuming that you found just the right view for the ostial left main to seal it. Once you do that, as you saw, the patient will do okay. The rest of the dissection will heal. So that was an excellent case and very informative. And I fully agree with the floating wire. I use that a lot to prevent the guide from getting sucked in. Any questions from the panelists before we go on to the next case?
No questions, but yeah, I think it was a great case. And whenever we do integrate CTO PCI, it's always a balance between good backup and from the guiding catheter and the risk of injury from having such an aggressive guider. So unfortunately for you in this case, the backup came at the expense of a left main dissection. Can I just ask, at which point did you realize that there was a dissection towards the end after all the stenting of the LED?
This procedure was very long procedure, about 1.5 hours, and during the final angiographic view, we noticed that there is a dissection in the ostium and the proximal part of the left main. During the final angiography,
I think it was at the very end.
Expect it at all.
Sure.
Oh, I performed CTO PCI bilateral approach many times. So we use guiding curtain with side hole every side. Yes, it's very it's good for bilateral injection with side hole guiding catheter, I think.
Okay.
Great.
Yeah. Can I just confirm what French size was the guiding catheter? How big was it? Sorry?
6 French. XP
Yeah. How
3.5.
many French? 6 French.
It was a 6 French guide, yes.
Okay.
6.5. Oh, was it a sheet?
6 French, 3.5 XP.
Oh, 6 French. Okay. Oh, okay. Fine. Yeah. Actually, my own practice is sometimes I'm acutely aware of this kind of complication happening. So and you managed it really nicely. But sometimes I use a larger French size, like some French of, let's say, a softer tip guiding, like an Ikari left 4.0 to do cases like this. But the only disadvantage of that is that the support sometimes diminishes with time because the guiding catheter gets a bit soft after a while. But the Ikari guiding catheter, usually you can suck it all the way into the left main and LAD, and it's very atraumatic.
Yes.
I think in the interest of time, we should move on to the next case, Doctor.
Okay.
Great case, thank you.
Great case, yes.
Thank you.
The next presentation is by Dr. Siddhartha Mani from Rabindranath Tagore International Institute of Cardiac Service of India. He is going to share with us CRT-D implantation from persistent left-sided superior vena cava. Dr. Mani, please.
Thank you. Good evening, everyone. So it is an interesting case where we had to do a CRT-D implantation from a persistent left-sided SVC, superior vena cava. So my patient was actually a 58-year-old DCM patient with shortness of breath. It was NYHA class 3 to 4 despite 6 months of OMT. And on presentation, he was euvolumic, but I had a baseline 6-minute walk distance of only 200 meters. So he was quite symptomatic. And his blood parameters were more or less stable with normal renal function. ECG had an LBBB with QRS duration of 130 milliseconds. And there was an ejection fraction of 32% with generalized hypokinesia. He was already receiving these medicines, sacubitril valsartan, torsemide, eplerenone, and carvedilol. This was his ECG. You can see it is a broad QRS. He was in sinus rhythm and few associated STD changes as we expect in LBBB. So we do a routine venogram in each of our cases in pacemakers, AICDs, and CRT-Ds to rule out this anatomical variation, LSVC, and also to look at the anatomy, which helps us in guiding our catheters and wires. So while we did our normal routine venogram, we found that there is a persistent LSVC draining into a patulous and spacious coronary sinus. So now we had to approach from the left side only. We did not have the option of right side because of the shocking vector is not very optimal if we do it from the right side. So we started with to engage the coronary sinus from the right femoral vein with a AL1 catheter. This we did so that we can confirm the anatomy and we can put in a Teflon wire into the persistent LSVC, which will guide us as a route map. So this was how we engaged with little bit difficulty with the AL1 catheter, and then we confirmed the anatomy with a dye injection, and then we put in Terumo wire and kept it there, took out the AL1 catheter so that it helps us in future for the as a roadmap. And then normal, we took 3 separate punctures. We introduced our Teflon guide wires into the coronary sinus and then up to right atrium. And then we introduced the CS sheath, the coronary sinus sheath, over one of the Teflon wires. You can see, and then we introduced a multi-purpose catheter because this is an advantage to us that we are directly entering the coronary sinus through the persistent LSVC. So we can use the multi-purpose catheter just as a sub-selector, and we try to engage. Sorry, we tried to engage the our vein of interest, that is the posterolateral vein. And then we introduced the LV wire into the posterolateral vein of interest, and we placed it adequately. We found adequate QLV duration and adequate thresholds and impedance. So I stopped here. So after we introduced the LV lead, we had to go for the ICD lead for the right ventricle. It was a bulky lead, and because of the coil and its bulkiness, we had a little bit difficulty in manipulating it, and we had to make a almost 360-degree turn in the right atrium, so that from the CS right atrium, and then we had to cross the tricuspid valve orifice and enter into the right ventricle. But ultimately, we could manage to enter the right ventricle and found a good position, and we screwed it. So there was adequate threshold and impedance. And then again, we had some difficulty with the right atrial lead also, because from the CS, after it entered into the right atrium, we could not place it properly into the right atrial appendage. And repeatedly, it was falling out of position. And even after screwing 2-3 times, we found that it was not anchoring properly, and we were not having proper threshold. So we had to place our RA lead in the RA free wall rather than in the appendage. And there we found more or less acceptable pacing thresholds and impedance. So we had to keep it at that RA free wall as our final position. And this was during taking out the CS sheath, the LV lead got slightly proximally displaced, but we did not reintroduce it further because we were getting adequate threshold at that place also. So we kept it there, and this was our final position, where we ended our procedure, and we had adequate threshold QLV and acceptable post-implant QRS narrowing. So this is the post-implant QRS. You can see that it has quite narrowed a bit, and the patient was also doing well. He improved his 6 minutes walking distance of 500 meters at 3 months, and the ejection fraction improved to 38%. So the discussing points are CRT-D via LSVC has certain unique challenges as well as opportunities. LSVC draining proximally into the coronary sinus, so engaging the PLV was easy, and placing wire in the cardiac vein was antegrade rather than we do retrograde in usual cases. Right-sided AICDs are generally avoided because we lack good shocking veins, so we had to go through left side only. And the difficult part was maneuvering the RV lead into the via the CS into RV, and also placing the RA lead in RA appendage. But ultimately, we could get a satisfactory result. I don't have any disclosures. Thank you.
Well, thank you. That's a great case of improvising and being creative. I think in the interest of time, we maybe, is there any comment from the panel, a brief comment, and we probably need to move forward to the next speaker. If no comments, then maybe Dr. Sim, we move on to the next talk. Thank you for that great presentation.
Yeah, thanks, because none of us are from the EP team, so that's why I can't comment much. The next speaker is Dr. Haroon from National Heart Institute, Malaysia. She is going to share with us Make Heaven Out of Hell. Dr. Haroon, please.
Okay, my name is Afrah from National Heart Institute, Malaysia. I don't have any potential conflict of interest to disclose. Going to my case, actually, my patient is 82 years, male. He's a very good 82, self-dependent, very active. He's a golf player. He had a background history of hypertension and had a bypass in the year 2008 for a PS-line coronary total occlusion of the right coronary artery, total occlusion of the LAD, and tight proximal to mid-circ lesion. He had an angiogram done in the year 2018. It showed occluded saphenous vein graft to the circumflex and to the right side with a beta lemma. And the angiogram was done because he had a recurrent angina. He was advised for a redo bypass, but the patient declined because he said he's already 82 years. His ejection fraction was quite good, but he continued to have an angina in spite of optimal medical therapy. This is angiogram in 2018. So it shows a total occlusion of the right coronary artery, a tight osseal lesion at the distal, like at the osseal circ, mid-circ, and distal left main, and the lima was beaten. So because the patient continued to have a chest pain, so we decided to do a nuclear scan, at least to know which one of the coronary arteries is the right coronary artery or the circumflex to intervene. So the PET scan show a large area of ischemia at the distal right coronary artery with a circ and a big area at the circ territory. So we decided to proceed with the PCI to the circumflex, the native one, and then we can stake the right coronary artery if we can do that. So we go via a right femoral artery, 7 French EPU, 3-5. We pass a coronary wire, normal coronary wire to the circumflex, and we start dilatation. But you can see, like even the balloon cannot cross down easily. So this is a 2-5 balloon. Then we change with another smaller balloon, so we managed to cross. We dilate, and then we wanted to do an IVUS to assess our coronary artery. So the IVUS failed to pass through this very tight lesion. Then we proceed with a further dilatation with a bigger balloon, non-compliant. And then we managed to pass the IVUS catheter down there. So the IVUS showed the vessel size is around 3 to 3.5 at the proximal segment, with calcified plaque at the proximal and mid segment up to the left main artery. So we proceed, we decided because of a tight lesion, we passed a rota prayer of 1.5 to open up this calcified lesion, because it's calcified lesion, and earlier we tested with a balloon, like the balloon cannot cross down. So we do a rotablator, which it goes in smoothly without any issues. And then after the rotablator, we noticed some staining there. So what we did, yes, we passed an IVUS catheter. Actually, at this point, the patient was quite stable, has no chest pain, hemodynamically fine, and no ECG changes. So we passed an IVUS catheter, but the IVUS catheter, it didn't show like any perforation, clear perforation throughout the coronary artery. Just the calcium is well cracked out, and there is no dissection noted to us, like a perforation noted to us. So we decided to proceed with a further dilatation ballooning. So we use an NC balloon 2515, and then we use a bigger balloon 275. Then after that, we stent the mid circumflex with a 3020 stent, which is passed in easily. And then after that, we wire to the circumflex, the OM branch. We tried to put the second stent from the mid-circ to the left main, but the stent couldn't pass through. Actually, we find difficulty. Then we use a guideline to help. Actually, we continue with a further dilatation with an NC balloon, a bigger size. And then we try to pass the stent. Still, we can pass the stent down. And then after that, we use a guide liner. And even with a guide liner, actually, we found difficulty to pass the stent down. But after many manipulation, we put the second stent. And after putting the second stent, actually we deploy it. And then we see the perforation there. If you can see, if you can. So this one, after deploying the second stent, there is a perforation at the, between the junction, the proximal stent and the distal stent. So we decided to put the cover stent. And again, we found a difficulty to pass down the cover stent. So we use an anchor balloon, we use an NC balloon, and then we inflate it sequentially. And while deflating, we try to pass down our guideline. And you can see the guideline, it goes in smoothly with this anchor balloon technique. And then after that, only we managed to pass our cover stent. And then we put a 3026 cover stent. We cover the perforated area, and this is the IVUS post the cover stent. So actually, after the cover stent, we can see like some messy area, which is, it doesn't show the continuation between the adventitia and the Like at one place, that adventitia it wasn't seen very well. But there is no a real perforation that's seen at that point. But we try. I in the interest of time, so I will move it. So the stent was well opposed, well deployed. Actually, somewhere here, like we can't see the continuation between the adventitia. Like there is some area which is it a perforation or just a leakage of the contrast around the coronary artery. So since the patient was quite stable, has no more chest pain, no ECG. Actually, he had a chest pain, but there's no ECG changes, and hemodynamically he was quite stable. So we decided to stop at this point after putting the coverage stent. We did a bedside echo on him, and the echo, it doesn't shows any pericardial effusion, and the heart function, like there is no regional wall motion abnormalities. So we sent the patient to the CCU, and he was medic there for 5 days, and then after that we discharged the patient quite well. And we plan to do a repeat angiogram in 1 month after that. So at the discussion point, as we know, percutaneous coronary intervention relieves symptoms in patients with chronic ischemia despite the optimal medical therapy. And calcified coronary arteries usually is considered to be a marker of interventional procedure complexity and complication. And calcified lesions are the most challenging and the most likely to implement an adverse complication in acute and long-term results. And as we know, debulking is useful for optimal stent deployment. This is angiogram 1 month after we saw him in clinic. Actually, he has free of symptom, no more angina. It showed the stent is still okay. There is a staining around the stent, maybe just an adventitia, like the leakage of the contrast around. And you can see from this view, like the the left circumflex is supplied down to the distal RCA. It supplies a very big area. That's why the patient has no more symptoms and no more angina. So this angiogram after 1 month. So a take-home message from this case: usually calcified vessels such as this usually require a proper lesion preparation, and usually we anticipate this kind of complication in elderly people using a rota pair. Maybe we can avoid it if we use a smaller pair of 1.25. The use of a guideline and carpallion technique to deliver the longest stent, because the second stent was a little bit longer compared with the first one. And managing perforation with a cover stent, which is to some extent we consider as okay, because we use an IVUS to guide us of when to stop, because we were not so sure, is it a perforation or just a dissection or just a leakage of a contrast around the coronary. So with the IVUS, we make sure that it's not a true perforation. And as I mentioned, we repeat his echocardiogram, and the echo, it didn't show any collection of fluid around the pericardium, so there's no pericardial effusion. And always, yeah, you have to anticipate such a complication, and we shouldn't be panic and to look for the second plan. With this, I reached the end of my presentation, and thank you.
So thank you. That's a great talk. In the interest of time, we were short on time, but I think it's such an important case that you presented. Cheong, would you have done anything different in this case?
Yeah, I think it's a tough case. I don't know. It was. I might not have performed PCI in the first place to the circumflex. Didn't look like a really large circumflex to begin with. I just wanted to make a point about the use of IVUS. I think IVUS is very important in complex PCI planning, especially and also in complications. But I just wanted to make a point that it's very difficult to see perforations on IVUS. So by the time you can see, a perforation in the vessel on IVUS, it's right. Kind of too late. So I would not defer to using IVUS to rule out perforation, because there can be perforation which you cannot see on IVUS. So I just want to make that point about the use of IVUS in this case. But yeah, I think tough case, and well done for keeping the patient alive.
Adrian, in Hong Kong, you have shockwave. Would you have considered using shockwave for this case?
Yeah, actually, that was my point. The two points about this case. Well done for managing it well, and the patient did well from it. But number one is the circumflex is a monster. When you have a calcified lesion in the circumflex, it's always very difficult to bring anything down there. So think twice before you do any PCI on the circumflex with a complex PCI on the circumflex. And second thing is it's very deceptive. Somehow, all the perforations and dissections, etc., always happen in the circumflex. Most recently, in our cath lab, we had one such case. We pre-dilated a heavily calcified napkin ring lesion with a 2O NC balloon, and that perforated for no good reason. So think twice, and be very, very careful and gentle. Respect the circumflex. Now, third thing is, instead of using rotablator in such a angulated lesion where the risk is rather high, yes, a shockwave is an invaluable asset. However, delivering the balloon down there would be a nightmare. You would use an anchoring balloon technique probably to get it down there, and maybe you would need to use the guide liner as well to get it down there. But yes, now that we have this new weapon, it has made treatments of these heavily calcified lesions much less stressful.
Great points. Dr. Sim, I think we need to move on to the next talk. Thank you, Dr. Afrah.
We have one great case of perforation. We are moving to another case of perforation. This time we have Dr. V. Roy from Chulalongkorn Hospital, Thailand, to share with us coronary artery perforation. Dr. V. Roy, please.
Okay. Good evening, everyone. My name is Viral Mungsirmasat from Chulalongkorn Hospital, Thailand. Today I'm going to discuss about a coronary artery perforation. So the medical history: a 69-year-old Thai male with no known underlying disease presented with a typical chest discomfort over the last 2 months. The ECG showed T-wave inversion in V1 and V2 and pathological Q-wave in 2, 3, and AVF. At that time, the ECG showed triple vessel disease with critical stenosis at the proximal to mid LAD and proximal to mid RCA. At that time, PCI to RCA was performed with the 2 dilating stents, and today we plan to state PCI to LAD. And the right coronary system show the good all pattern stent and show the collateral vessel from the RCA to LAD. So we use the 6-strand XB35 with Cheong wire at the time. From the angiographic, you see that there were critical stenosis from the proximal to mid LAD. At that time, we start using the semi-compliant balloon 2515 for pre-dilatation, but you can clearly see that the balloon is not fully dilated at that time. So we check the angiographic again and try to use IVAS to access the vessel, but the IVAS couldn't pass through the proximal segment of LAD. So we changed to use the NC Scoreflick to 520, but you can obviously see the balloon is not fully expanded at the mid part of the balloon. So that's why we try to advance the IVAS again, but it couldn't pass through that area. However, we can get information from the IVAS that we can did at that time. So you can see the 360 circumferential decrease calcification at the proximal part of the LAD and significant stenosis from osteo to LAD lesion. So we try to use the NC Scoreflick 2.520 again for pre-dilatation, but it's obviously it's not fully dilated again at this point. So at that time, we think we have to change the strategy. Maybe at that time we changed to use a rotational arterectomy. So we use a rotational rotablator 1.5 blur, accompanied by the short ablation run about 15 to 20 seconds. And finally, we finished with the polishing run as the as shown in the angiogram. And now we can advance the IVAS to the distal segment of the LAD. And so what we get, a look at the IVAS. If you pay attention at the proximal part, you will see that the circumferential calcification was cracked by the rotational atherectomy radius. And the distal different vessel size was 2.8 millimeters, and proximal reference vessel size was 3.5 millimeters. So before stenting, we try to use the NC balloon 3015 again for pre-dilatation, and the angiographic show much better than before. And so we place the dilating stent 2.7533 at the mid part of LAD, and another stent 3033 millimeters at the ostial lesion to proximal part. Look at the angiographic data. It looks okay, but I think the stent is not fully expanded. So that's why we use the NC balloon 3015 for post-dilatation to start with the mid part to the proximal to ostial LAD part. After post-dilatation, as shown in the fluoroscope, so we do the angiogram again, but unfortunately, there's the choroid perforation at the proximal part of the LAD. So the problem list now is choroid artery perforation at the proximal LAD. So what should we do now? Because we are very excited now because this is my first case to see the choroid perforation. But because this is the proximal part of the LAD, so that's why I made a decision to do the prolonged balloon inflation and prepare the cover stent at that time. So we use the NC balloon 3015 for prolonged inflation. At that time, we inflated about 2 to 3 minutes because the patient developed chest pain. So we have to deflate the balloon, and we check the angiogram again. And angiogram looks a little bit better, but still having the perforation at the proximal part of the LAD. So we try to prolong inflation about the balloon 3015 again for 2 to 3 minutes at that time, and check the angiogram again. And angiogram looks better, but still have an exacerbation at the perforation point. So at that time, we applied, made the decision to apply the stent graft TO18 to cover to seal the perforation point. And this is angiogram after inflated stent graft. It's look good with good TME flow. And at that time, we do the echocardiogram and show just minimal pericardioid efficient with good hemodynamic stability. And finally, we use this IVAS to check a stent apposition, and the IVAS show stent have a good apposition, and the stent graft is show the fully expansion about the size that we use. And final angiogram shows, as shown in the angiogram, is good TME flow tree with hemodynamic stability at that time. And this question point is, so what is principal part of choroid perforation in this case, and which strategy do you recommend for performing PCI in this case to prevent choroid artery perforation? And my take-home message is, when facing the serious complication, please stay calm. And choroid artery perforation is a rare complication, but it's just high morbidity and mortality. So hemodynamic status, location, and individual choroid anatomy are very important to determine the treatment strategy. Don't forget to stop the bleeding first by using the prolonged balloon inflation, and urgent serial echocardiographic monitoring is mandatory, and quick pericardiocentesis should be performed if needed. Thank you.
Thank you. That's a fascinating and really interesting case. Now, I have a couple of quick questions. Dr. Fujimoto, would you have done rotablation up front rather than later? And would you have put a covered stent early rather than later in this case?
I think after rotablation, I use cutting balloon or some scoring balloon. It's useful for this case, I think. And after perforation, I use perfusion balloon. Perfusion balloon is available in Japan, named Yousif. Such a balloon is very used long time, but the inflation is possible. Yes. But
the question is, this is an LS3 perforation. Do you expect it to settle with the perfusion balloon?
Yes, but in this case, after that, I use covered stent. Yes, the same And I had much experience of coronary perforation during PCI. So I use graft buster over 20 or 30. Yes. In such a case, after graft buster implantation, more large size non-compliant balloon is necessary, I think.
And would anyone in the panel have rotablated up front? I mean, there was clearly calcification in the artery. Cheong, would you have just gone straight with the burr, or would you have ballooned first?
I think it's always tricky if you balloon first, then you introduce some dissections, which then makes it a bit more tricky to do your rotablation. Right. I don't know. I sometimes try to use a balloon first, and if the balloon expands, then we can get away without doing rotablation. But you're right. There is benefit if you think that there's a lot of calcium to just go up front with a rotablation strategy.
I think that's sort of what we have adopted, that a balloon doesn't go easily. You can see visible calcium, just go ahead and ablate it. And we found that to be much safer. But, I think this is a very nicely handled complication. It was potentially catastrophic. It's a, full-blown LS3 perforation. So congratulations. It's a great case. I think we'll move forward in the interest of time, and Dr. Sim has had to leave. So our next speaker is Dr. Harinder Bali from Paras Hospital in India, who's going to be talking about left main equivalent bifurcation stenting of a saphenous vein graft in a patient with a previous rare SVG intervention. So that's an interesting title. Dr. Bali, all yours.
Yeah. So this is a very interesting case. Good afternoon to all of you. First, the relevant clinical history. My patient is an 83-year-old male. He's a known case of coronary artery disease, diabetes, and hypertension. He had presented to us with an exertional angina, which was grade 2/3, and it progressed to almost rest angina. Echocardiography had shown a preserved left ventricle function with regional wall motion abnormality. Yeah. If we look at the history of this patient earlier, in 2011, he had undergone a bypass surgery with a jump graft, venous graft to LAD and obtuse marginal, and a venous graft to posterior PLV branch of right coronary artery. In 2014, he had undergone PTCA and stenting of left vein to LAD for his problem of angina. In 2015, we did a PTCA and stenting of ostial flush occlusion of CTO of this venous graft, jump graft, which was supplying to left-handed descending artery and the obtuse marginal artery. This was a very interesting case, and we had done it from a retrograde procedure. And this is the screenshot of what we had done at that time. So there was a occlusion, there was a flush occlusion of the venous graft, and there was we went retrogradely from the circumflex. Circumflex was very heavily calcified and diffusely diseased, critically narrow. And we negotiated the wire from the native circumflex to obtuse marginal, went into the obtuse marginal limb of the venous graft, and opened up the ostial CTO of this venous graft retrogradely. We tried to snare that wire. We did not succeed, so we ballooned it with 1.5 millimeter. Then we had an antegrade access, and we passed one wire into the LAD limb of the SVG graft. So we had one wire in the obtuse marginal graft, and then one wire into the LAD graft. And we did an angioplasty stenting of that venous graft, putting the one stent only from LAD, left vein to LAD, left vein, the main venous graft into the LAD segment of the venous graft. And we did a post dilatation of that stent, and we had very good flow into both the limbs, the LAD limb and the SVG graft. So retrograde angioplasty stent of venous graft done at that time. He came back with angiography, with angina progressive, and this time he had ISR of this stent, which we had put into the venous graft. And you can see a critical narrow in this stent, and there was a narrowing at the origin of the venous graft limb to the obtuse marginal also. So we decided that we are going to deal this ISR of venous graft bifurcation venous graft with a bifurcation stenting of this thing, which is equivalent to a left main stenting. So we had a left main equivalent of SVG disease. We had a bifurcation lesion in the SVG with a previous intervention in SVG, and he had multiple comorbidities and advanced age. So we decided to go ahead and do a mini crush technique in this patient, right femoral root, 7 French AR guide. We used BMW guide wire to cross the region, and then we went ahead and did a mini crush technique on this particular patient. And you can see that we passed 2 wires, one into the SVG, into the LED, and one into the SVG, into the obtuse margin part. This is a normal BMW wire. We dilated with BMW with a non-compliant balloon, high pressure dilatation, with 4 millimeter balloon. And after that, we did a side branch balloon angioplasty. So we had angioplasty of the venous graft to LED and angioplasty of the venous graft to the obtuse marginal. And then we deployed a stent into the obtuse marginal branch, used a balloon to in the LED part of the venous graft for crushing. And after deploying the stent, we crushed that stent into the LED. And then we deployed a stent, long stent into the main branch, into the LED venous graft. And then we went ahead and did we dilated the side branch and did a kissing balloon. First part, then kissing balloon, and then you see the kissing balloon angioplasty being done. And then we did a final part of the proximal segment of the venous graft bifurcation segment. And this is after a good part with 4.5 millimeter balloon. You see good flow into the venous graft, into the obtuse marginal, and good flow into the venous graft, into the LED. So this is what we got finally. Both the limbs are flowing very nicely. So he was discharged on the second day on usual antiplatelet with aspirin and clopidogrel and beta blocker and statin. We have a 12-month follow-up on this patient. He's angina-free and doing very well. So percutaneous coronary interventions of venous graft has higher rates of mortality, periposterior myocardial infarction, and restenosis when compared to native vessel PCI. Due to their low incidence, there has been no data concerning treatment of bifurcation lesion in wide saphenous venous grafts in the literature. These communications are limited to anecdotal case reports only, and in therapy of these cases, we can rely on PCI of analogous lesions what we use in native circulation, considering the specifics of the intervention in saphenous venous graft. So in conclusion, I would like to say that bifurcation stenting of RCD, venous graft to LED and obtuse margin graft was done, which can be considered equivalent to a left main bifurcation intervention. This is one of the very few cases of successful venous graft bifurcation stenting reported worldwide. And this case demonstrates that mini crush technique is feasible for PCI in bifurcation lesion of venous graft and provides a very good angiographic result and favorable intermediate term clinical outcome. So that is what my case was all about, an interesting case. And now I can take care of, answer your questions if there are any queries to that.
Well, thank you, Dr. Bali. That's a very interesting case, I must say. It's not something you see every day. Dr. Fujimoto, as a CTO expert, I'm going to put this question to you, the obvious question that opening up a CTO of a graft and then doing a bifurcation stenting in a graft versus doing the native. What are your thoughts on that, and how would you approach this? The fact is that the patient did well, and 12 months later, he is doing well. So would you have approached this any differently, or would you have gone for the native or actually opened the graft?
Oh, I think recently I never use mini crush technique because side branch restenosis is high. So yes, but in this case, mini crush is acceptable, I think. Yes. I don't know much about native coronary artery in this presentation.
Did you all consider, Dr. Bali, did you consider doing a CTO PCI of the native arteries? And I know that's easier said than done.
No, we did try a native coronary artery, and obviously in all patients who have occlusion of the suffering from the graft, the primary indication is to go ahead and open up a native coronary artery. In this patient, we could not do that. We did not succeed in doing a native coronary angioplasty stenting, and that's why we chose to go ahead and do a venous graft bifurcation angioplasty stenting.
Cheong, any thoughts on doing a CTO of a vein graft? That's not something we come across every day. I'm talking about the previous procedure prior to this procedure.
Yeah. No, you're right. I've never done it, but congrats. I mean, it was in the end, after the second procedure, it turned out to be good. But yeah, I mean, I can't remember, like Dr. Fujimoto said, I can't remember what the native vessels look like. So I can't quite comment on whether the native CTO or native disease PCI would have been feasible. But yeah, not something I would generally embark on, CTO PCI of the grafts.
I think I will just take a minute to explain the previous procedure, because previous case had been presented in a couple of conferences, so we did not spend too much time on talking about that. Previously, what he had was a left main to LAD stent, and then this jump venous graft, which was flush cut at the ostium. So this venous graft was filling retrogradely from the obtuse marginal branch and then filling the antegrade limb of the LAD. So there was only a small segment of ostial flush cutoff of this Y graft. So Y graft was not diseased, only the ostial cutoff was there. So there was a retrograde filling of obtuse marginal limb and antegrade filling of LAD. So this obtuse marginal was heavily calcified disease segment. So therefore we went retrogradely and opened up that short segment of ostial CTO. And then we went antegrade and opened up. The rest of the venous limbs were not diffusely diseased. They were not extensively diseased. It was a short segment ostial flush cutoff. That is why we chose to go ahead. But that has been presented previously and published also, so I did not spend too much time on that particular case. So I spent time on today where it was a bifurcation lesion of that venous graft which had undergone a procedure earlier.
Well, I think it's a great case. Thank you for sharing it. I think everyone will learn something from it. I think we'll move forward to the next talk. The last presenter is Dr. Cheong from Vietnam National Heart Institute, and he's going to be talking, his talk is The Danger at the End of CTO Intervention, How to Manage Septal Perforation. Dr. Cheong, all yours.
Hello, everyone. Today I want to introduce you my presentation named The Danger at the End of CTO Intervention, How to Manage the Septal Perforation. I have nothing to disclose. Firstly, I want to introduce the baseline. It is a female patient with 71-year-old. He was hospitalized because of symptoms of heart failure and angina pectoris on dissection, hypertension, hyperlipidemia, and diabetes. He also has previous STEMI 3 years ago and has put the DS stent on proximal and mid-LD. Echocardiography show the mild reduce in left ventricle with EF 45% and hypokinesis in one motion. The ECG finding show no FTT change and TNT serum is no elevation. You can see the angiography baseline of patient. The count of view show the good flow in and but in RIO you can see the nice restenosis on reverse stent. You also see the good collateral connect from LD to PDA. Like you can see the lesion on mid RCA with total of occlusion, and the length is quite long. You also see the of RCA is quite high and abnormal. Regarding on angiography, we decided to select radiography PCI with guiding catheter in left coronary EBUs 7 French, micro catheter in the Caravelle 150, and YY is cyan black. To facilitate advanced micro catheter, we pre-dilatation with previous 10 LD with NC balloon. Then we easily to advance microcatheter and cyan black to the PDA to the mid PDA. Then we escalated YY from to cyan black to Gaia first to Gaia second. Finally, we successfully to cross obstruction and we externalization YY by to engage guiding catheter. The YY we use is a azitert. Next, we advance Caravelle as little PDA, and next step we do a PCI annually with the pre-dilatation at lesion obstruction and put 3 stents from little to of RCA. You can see the result. On left hand panel, you can see at the tip of Y arrow, you see the stain contract. We notice is a perforation of collateral. Basically, on right panel, we use a tip ejected microcatheter to confirm the perforation. On clinically, the patient had no symptom. He had no angina. But on echocardiography, we found the echolesion in septum. So we decide to embolize. We occlude the perforation. On that time, in our cath lab, the coil embolization was not available, so we decided to use the pseudo coil. We created the pseudo coil by cut little part of balloon. So we insert it first and use a new balloon to deliver tip top of balloon to the on-site. In the mid panel, you can see the tip of red arrow is a pseudo coil. We use a balloon of Ryu 2.5 and delivery balloon is 2020. After we put first pseudo coil, we recheck by user contact, but the Z is still, so we decide to put another tip on perforation. The Second one is a tip of is on tip of blue arrow. Final check contrast ejection. You can see the stain contrast is not increasing and patient has free of symptom. Cardiography shown no pericardial effusion, so we decide to stop procedure. Some question I want to show you is which is the best option on this controversy or variation and psychomassive potential complication of retrocitial intervention could appear any step. Septal perforation, septal hematoma, sometimes angina, can cause hemodynamic collapse. Management of septal perforation by cutting tip of plain balloon could efficiency to stop the bleeding.
Thank you, Dr. Tran. It's an excellent presentation. If you could unshare your slide. So very interesting. Dr. Fujimoto, can I get your comments on how you prevent and then manage septal perforation like this?
In this case, was there any hematoseptal? No. With echocardiography, no septal hematoma.
Dr. Tang, the question is to you.
Can you repeat? The question?
In this case, septal hematoma was seen with echocardiography. Yes. No.
Yes. We in echocardiography we see a free space in interceptor. Yes.
Yes. If there is no septal hematoma, no treatment, I think. This only no ballooning or such any treatment, I think.
Do you have any idea, any sense of why it might have happened? Is this just something that could be avoided, or in this particular case, or was there a way to prevent this from happening, in your opinion, Dr. Fujimoto?
Maybe advancing microcatheter such a perforations occur, but it's difficult to prevent such a tiny channel. Yes, I think.
Are there any other comments from the panelists on this case before we wrap up? Okay, well, I think, this has been a great session. I mean, I think we saw some quite an interesting gamut of cases, from an aortic dissection to, a lead going into in an awkward position in a vein for a CRT, a couple of coronary perforations, a unique, graft case. And I think the bottom line of all these cases is that, as interventional cardiologists, we are always improvising and thinking on our feet, and sometimes having to keep calm when things go badly. And we saw some cases that were very nicely executed, and also complications that were very nicely handled. And certainly it reflects not only the skill and prowess of the operators, but also the ability to improvise when you're on your feet. And I hope that from this session, everybody will take some learning points and learn from it. I'd like to thank my co-moderator, Dr. Sim, who had to leave early, our panelists, and certainly all the presenters, as well as the audience for watching. Thank you very much, and all the best to everyone. Thank you.